Hello and welcome to another episode of the TheSynapse e-learning series. With us today we have Dr. Gauden Galea, who is coincidentally one of the original founders of the TheSynapse with Dr. Wilfred Galea more than 20 years ago, and is also the WHO Director for Non-Communicable Diseases and Promoting Health through the Life course in the WHO Regional Office for Europe. Dr. Galea, thank you for being with us here today.
Thank you for having me.
It's a pleasure, and I would like to start off by asking you, what does your work actually entail in the WHO?
It services the 53 member states of the European region, which basically covers all of Western Europe through to Central Asia. The 53 countries include the European Union, include countries of the Southeast, the former Yugoslavia, and the countries of the former Soviet Union. To summarize, they represent a range of countries with very different economies, from upper middle income to very high income countries. They share a number of characteristics. For example, in all of them, for different reasons, there is a major epidemic of non-communicable diseases. They are the major killers in all countries. Countries of the East suffer more premature mortality than countries of the West. All of these countries are recently have started to decline in premature mortality. They're all doing better than they were 10 years ago, and this is a very heartening situation that this decline is not shared by all other regions of the world, but still the major killers of the population in these countries in all of Europe, whether East or West, are the non-communicable diseases. The four major ones: cardiovascular diseases, heart attacks and stroke, diabetes, cancer, and chronic respiratory diseases.
So on a practical level, what does your work entail then? So these four main non-communicable diseases obviously pose their own challenges. How do you tackle them on a regional level?
We approach them in, basically I would classify our work as being a public health, population-based approach, as well as supporting high-risk approaches within countries. I'll just explain what those two are. A population-based approach means setting the environments that make healthy behaviors easier. So making the healthy choices the easy choices, as we have been saying for a number of decades in health promotion. For example, it's easier to buy local food. It's easier to buy fresh vegetables if they are cheaper and available locally. So that's a very important distinction, that you can't adopt behaviors which are prohibited by your environment. So in this, therefore, in the population-based approach, one tries to propose and advocate for evidence-based policies, laws, control of prices, control of advertising, in such ways as to promote healthier behaviors in the population. The other side of that is that there is a clinical or a high-risk approach. There are people, not just the people whom you want to prevent the onset of these diseases, but you want to help people with these diseases already, who have high blood pressure or diabetes, to better control their conditions in order to reduce the risk of progression, or indeed to keep them on a stable situation with less complications and less morbidity.
That being said, from your own perspective, is prevention better than cure?
It's a nice proverb, but it depends is the answer. The evidence is quite a... It depends on which country you are coming from and what is the epidemiology. I'll explain what I mean in practical terms. If you look at the decline in coronary heart disease mortality and deaths from heart attacks over the last 20-30 years in Western Europe. A number of studies have been done using something called the impact methodology to try and tease out which part comes from the reduction of risk factors, for example, the reduction of tobacco or alcohol consumption, versus which part comes from medical interventions. And you can see that consistently about 50 to 60% of the improvement that we have seen in industrialized countries comes from population-based approaches or from the reduction of risk factors in the broad population. But that still leaves you with something like 40 or 30 to 40% that comes from the high-risk interventions, the evidence-based approaches in the clinic. And that's a proportion that is not negligible. So it might be that the edge is in favor of population-based approaches as foundational approaches, but certainly there is a lot of scope for action at the clinical level.
And from your point of view, any new projects which you're currently trying to push forward within the European region?
Many such projects. But there's a big interest in always finding new ways of producing effective population-based approaches. So we have a number that are well established in the evidence, but we also have new challenges that we have to look for solutions and find the evidence to support a coherent policy approach in countries. Again, let me try and say and describe what that means. So non-communicable diseases are an old problem, and there are many well-known old solutions. Take an example, tobacco or harmful use of alcohol or inappropriate diet or insufficient physical activity. We know that these are the 4 major risk factors, and we also know what are the evidence-based approaches to deal with them. Price, availability, and marketing are extremely important interventions on tobacco and alcohol. Raise taxes, prohibit advertising, reduce the availability or sales, provide services for smoking cessation or for treatment of alcohol dependence. So there are a number of such well-established interventions that have been in the canon of the evidence for the last 20-30 years. Then there are newer challenges that one needs to still work out how to find an appropriate solution. For example, we have discovered that in some of the traditional local food markets in Eastern European and Central Asian countries, even the traditional foods that are sold in local markets are being manufactured, even though they're home manufactured and not coming from some big anonymous multinational firm that has proprietary ways of formulating its own food products. But these locally produced foods are really very high in trans fats, in salt, in sugar, and in other types of fat. And therefore it's not easy to just simply say eat your local foods, because some of the solution here is not clear how people are going to access healthier foods if processed foods are high in fat, sugar and salt, and so are local ones. Then one needs to really work hard to find whole of society solutions to this sort of problem. Another issue that we are working on is the area of digital marketing of foods to children, and also the digital marketing of alcohol to young people. It's a growing problem indeed for many segments of the population. Digital marketing is the way that companies reach them to entice them to smoke or to drink, to draw them in to the habits. And this is an area that is not as yet well controlled. Indeed, many laws are much more outdated than the technology. So while we have well-established problems, we also need to find solutions to extremely important new challenges.
I understand that a significant portion of your work involves transnational collaboration with governments and entities on mostly a political level, I can imagine, to try to change laws and change customs. And since this, obviously, our audience is mostly consisting of medical professionals, people who are on the ground, meeting patients every day, how can we help you face the challenges which you're currently facing?
So what can clinicians do? If one looks at what we call fondly Annex 3, this in 2013 WHO proposed and the World Health Assembly adopted the Global Action Plan for the Prevention and Control of Non-Communicable Diseases. And within it, Annex 3 listed the cost-effective interventions that will work at population level and at high-risk interventions. And now, as of this year, the World Health Assembly has adopted an update to that in its proceedings, looking at the more recent evidence on what is cost-effective, focusing especially on what's even cost-effective in low-income countries. That means what are the interventions that even the poorest countries of the world can afford in order to address their non-communicable disease problem. So there's a long list. We don't have time to go through them in very great detail, but there are a couple of things that clinicians can do. One is, in every country, the medical profession is organized, and it is a credible voice in policy making. Indeed, in many countries, even the president or the head of state is medically qualified. The medical associations, the professional associations, the heads of state and the ministries of health all have a very strong clinical and medical presence among them. It is important to realize that the responsibility, therefore, of the physician doesn't just end with the clinic, but it enters into their political activism. And it is very clear that in many countries, historically, the medical profession has been one of the main motivators for healthy laws being passed, whether it is to control the availability of alcohol, to raise the price of tobacco, to ban advertising. The voice of the medical profession and the community is very strong. So consider yourself not just as a lone practitioner, but as part of a broader movement. Secondly, in the clinic, reading Annex 3 or the best buys list for non-communicable diseases, I hope we will have a link to this document and the solution in the description of the video below. You will be able to see a long list of possible interventions, namely, for example, brief interventions for tobacco, brief interventions for the harmful use of alcohol, brief interventions for the promotion of physical activity. These are, as the name implies, minutes long, very brief interventions where one, for example, assesses whether a person has a smoking problem, that whether they smoke or not. Every physician should know whether each of their patients is a smoker or not. It's not really serious to be providing any therapy to people and not know their smoking status. So knowing whether they smoke, motivating them in order to change their behaviors, to consider stopping, and providing them the support and the solution to whether it's pharmacotherapy or counseling in order to help them to stop. And if the person needs more intervention, then sending them on, referring them to a more specialized counseling or smoking cessation service. So there are analogous interventions of this nature for tobacco, for alcohol, and for physical activity. Also, within the area of cardiovascular diseases, the control of blood pressure and the control of diabetes are extremely important. It is very well known that you have to have control of blood pressure, control of blood glucose for the duration of life for people who have these conditions, if one wants to get the benefits for future health. The treatment, the acute treatment of myocardial infarction and stroke, their early recognition, immediate referral, and quick access to anticoagulant services, for example, can save a lot of lives and return to normal function much more rapidly. And in the area of cancer, the appropriate use of human papillomavirus vaccination, hepatitis vaccination, and the appropriate screening for cervical, breast, and colorectal cancer are important interventions that all clinicians should consider with the patients of the appropriate stage. And of course, the treatment of chronic lung disease, asthma, and chronic respiratory diseases with the appropriate pharmacological agents are an important set of interventions. And this complex in itself, however, it's actually quite simple and well established and long standing, it may seem, but the systematic application of this group of interventions with every patient who needs them is going to make a very big impact on a public health level.
On to my very last question, because we only have a minute before we conclude. If I am a medical professional and I want to know more about the interventions and the policies of the WHO, what is the best resource for me to access?
I would start with the best buys list, and that has a lot of references, and it can take you forward to the source of the evidence. I think in that context it will be extremely useful to be able to understand why this list has been compiled and how to apply and adapt it to one's local situation.
Dr. Galea, thank you for your time. It was an opportune moment to have you with us here today, an invaluable input. Since you were visiting Malta here, we thought we could actually ask you to perform this short and brief interview, and we hope that our discussion has helped to further elucidate and clarify the details of the work which WHO does, both on a national and the regional level, and how it can apply to you as a clinician. Thank you, and keep on subscribing to the TheSynapse Facebook page.